Most drugs were composed of small molecules, which are developed in laboratories by using chemical building blocks that are bound together in discrete chemical steps. There could be multiple methods to manufacture them, allowing the drugs to be duplicated and sold by multiple companies when patents expire. Small molecule drugs include most drugs taken orally, in addition to some given by injection. In contrast, biologics are usually proteins, can be up to 1,000 times as large as small molecule drugs, and are given by injection or infusion. Because of their complexity, biologics must be manufactured in living cells. Since their introduction approximately 30 years ago, biologics have helped more than 325 million patients worldwide. Manufacturing a safe and effective biologic medicine requires tremendous effort and vigilance. Every step is critical. It is this rigorous commitment to quality that helps ensure that each dose is both effective and safe for patients.
Okay.
The challenges in manufacturing biologics. A key objective in medicine is to improve patients' health while ensuring their safety. One breakthrough that has revolutionized medicine and helped meet this objective is the development of a newer type of drugs called biologics. More than 200 biologics have benefited millions of patients worldwide. Biologics are very complex molecules. Because of this, each step in their manufacturing requires rigorous quality control and testing to ensure their efficacy and safety.
Okay, shall we start? Bismillah ar-Rahman ar-Rahim. I have the honor to start this session. I am Baha Abbas, one of the board members of the Egyptian Society of Inflammatory Bowel Disease. I have the honor to join Professor Ahmed Shawqi, Ali Gaballah, and Medhat Al-Sahar as chairpersons. And we'll have a very eminent speakers in this session. And I will give the mic to Professor Ali Gaballah to introduce Professor Osama.
Thank you, Professor Baha, for your welcome. I have the pleasure to share in this distinguished meeting the third international conference of the Egyptian Society of IBD. I'd like at first to thank the organizing committee. I'd like to thank Professor Osama Abada, Professor Amr Futin, Professor Mazen Naga, not in a special order. This is the first session, inshallah. And I'd like to thank as well the organizing company, Alpha Medical and Barcode, and in particular Engineer Ahmed Asim for his distinguished preparation for this meeting. I'd like at first to welcome all and start the session one by the first talk, Professor Osama Abada, the pioneer of IBD in Egypt. He will present a talk about the present and future therapies in IBD. Professor Osama Abada.
Hello, everybody. Thank you very much for the kind presentation, Professor Ali. I'll try to speak to you about the current and future therapies in IBD. I'll try to concentrate. Currently, we have the anti-TNF therapy for IBD, which is the started with the infliximab, adalimumab, golimumab, and certolizumab, and they have been there for a couple of years now and have been the standard of our current therapy. And their effectiveness as a combo therapy, as you see, as you have seen in the previous workshops, have been standard since the SONIC trial for Crohn's disease and success trial in ulcerative colitis. for years now, and it is better to be combo at least for infliximab if not the other anti-TNF. Also, the CALM study has established our new treatment, which is the treat to target. And in the CALM showed us that the treat to target is superior to the clinical management that we used to use for years before. Also, it has been standard for currently that we can switch biosimilar to the originator without losing our efficacy. What about the rest of the molecules we have? We have actually four kind of groups of drugs. First is what we talk about is the cytokine targeting, which is the cytokine, and the anti-TNF and others we are talking about. But we have others like cytokine blockade, like anti-IL-12 and 23, and the intracellular signaling like JAK inhibitors, and lymphocyte trafficking blockade like anti-integrin. We'll talk about what is recently approved there. So we have the trafficking and we have the inhibition of inflammation with an extracellular like interleukin inhibitors, intracellular like JAK inhibitors, and the regulator trafficking is the integrin inhibitors, and you have still investigation two groups like MAdCAM and S1P modulators. The integrin and the MAdCAM, they prevent the migration of the lymphocytes through the blood vessels. The MAdCAM works on the vascular endothelium, and the integrin works on the lymphocyte wall. We have two drugs being there, natalizumab, with the main concern of PML that limited its use to Crohn's disease and limited its use to the our management. Vedolizumab now has been used, approved for both Crohn's disease and ulcerative colitis, and this has been the study for approval of ulcerative colitis, and this is the study for approval for Crohn's disease. But what is recently in the last 2 years that we have also the VARSITY study that compared the vedolizumab to adalimumab, and it showed that the Vedo is better than adalimumab by a certain about 9% point more, and the response has been percent to all over that for 52 weeks over 1 year. So we have a histologic remission, and the VARSITY study proved that Vedo is better than, at least in this study, than adalimumab. What also recently published that the Vedo does not impact the effectiveness of subsequent TNF-alpha. And this is a concern that we can, whether in the second line, we can use the Vedo as a first line. If it failed, it didn't disqualify the patient or decrease the chances of the response of the second biologic as a responder, both if it is first biologic and second biologic, there is no difference. Also, in this study, the combined endoscopic histologic healing by Vedo in refractory Crohn's disease, and we showed that about there is an improvement both endoscopic and histologic, and now the histologic remission is our target, or our aim to be our target. The mucosal healing is even endoscopic remission, and then the Roberts histopathologic index as a sort of target of our treatment. Also, this recent study showed that if you use Vedo, you can use it, you can't re-escalate, and you can maintain your remission of every 8 weeks. 86 maintain their response, while you need only about 4% that you need to escalate to every 4 weeks. Also, recently, the Versify study in the Vedo has been proved to improve the complete mucosal healing In anti-TNF naive, about 60%, overall population 54, and the failure, of course, anti-TNF is less than the naive patient, but we can have endoscopic remission, as well as this was the first study that showed the MRI radiologic remission, and we have Maria Index to be as a sort of measure of induction of remission. Also, this is a study here showed that we can predict, we use the Gemini study cohort and the Victory consortium, and they said that if we can have those points prior about surgery, prior to anti-TNF, prior to stabilizing disease, baseline albumin, and baseline CRP. And with these predictors, you can say if the patient have a low probability of response or high probability of response, and this can help us in predicting whether this patient will benefit from Bedu or go to another drug. Also, recently, this month, this has been a study showing that we can have 4 genes in the colon, and these 4 genes, you can make a sort of here a curve that the patient can predict whether they can respond to Vido or not up to 80-something%. So you can, by having the biopsy from the colon and having staining them, you can predict whether they can enter the remission or not in about 85% chance. Other alpha integrins, this AGM 300 has been tried. Also, etrolizumab, this is from Roche, and has been tried, but still under a trial, and it was well tolerated, both in anti-TNF naive and anti-TNF non-responders. Another alpha-4 beta-7 integrin, abrinomab, has been tried and well tolerated, but not have good results yet. SHP647, which is the MAD-CAM inhibitor, has been tried, and this is the results a couple of years ago, but we didn't have recent results for that molecule. Second group is the S1P receptor, which is used to block the receptor in the lymphocytes. And we have 2 investigation drugs, the estrasimod and ozanimod, and both has been under trial. This trial, the estrasimod was used in UC, and this is the dose finding, and they found that 2 milligrams POQD is better than the rest, and that's why they use it. And here they use it that this 2 milligrams has been sustained and improved for up to 46, and this is published just a few months ago. The ozanimod also has been tried in UC with good results for the 1 milligram dose. What other groups we have? We have the extracellular inhibition cytokines with the interleukin inhibitors, or intracellular, which is JAK inhibitors. The interleukin inhibitors, we have the approved ustekinumab, which is IL-12/23. The rest are anti-23 only, and Riza, Miriki, and Brazi, and the rest. And this is Unity 1 and 2. They had the approval of the use of ustekinumab in Crohn's disease, and the Unify study, which have the approval of use of ustekinumab for ulcerative colitis. Also, this is a few months ago, they published the extension study, which is the Unify study for week 92, and they showed that it maintained more than 97% of patients were corticosteroid free, and they maintained response for 92 weeks or about 4 years. Also, this is the extension of phase 3 Unify study, and these are the results endoscopic and histoendoscopic activity, and this is the trend from now on, that we will have that all our data to have histology and endoscopic response. Also in this study, was in the UEGW 2019, published this month in the CGH, and they show that the patients who have clinical remission, on induction, They maintain remission clinically, endoscopically, and histopathologically all the period of 44 weeks of the study. Other interleukin inhibitor, brazikumab, has been tried in Crohn's disease. Mirikizumab also has been tried, and this is mirikizumab has been used in ulcerative colitis too, and this results in ulcerative colitis. Risankizumab has been tried in Crohn's disease and started to be used to be tried in ulcerative colitis. The JAK inhibitors, the intracellular, the approved is the tofacitinib, which is the poly-JAK, which is JAK 1, 2, and 3. The others, filgotinib, opatinib, they are oral and they are JAK 1 only. And this is topical. TD1473 is a topical use. And the OCTAV study, which is the study that have approved the UC, the use of tofacitinib in UC, but not in Crohn's disease yet. But the summary of tofacitinib safety, we should have that the response that they have dose response relation exists with serious infection, herpes zoster, but no dose relation to malignancy whatsoever. Fligotinib, as JAK inhibitor in Crohn's disease, has been tried. Upadacitinib has been tried in CD, and the dose of 24 BID was the best response, and that's why it has been used here for to continue at 45 now as extension release and have best results to be 45 and or above 30 milligram to be the standard use for upadacitinib in their studies. The other pathways, the phosphodiesterase E4, the apremilast, this has been tried in UC. This monoclonal has been used for COPD also. PDE4 modulation in UC has been tried, but still the results has been published as an abstract in ECHO 18. There is a novel treatment consideration, which is the combination approach, the biological combination, the small molecule with biological, and the antibiotics and the others. So, but the combination of biologics, we were afraid of course, the immunosuppression, and this is the last published reports of about 6 studies showing that improved using of various biologic infliximab, natalizumab, infliximab plus Vido, infliximab or ADA plus ustekinumab, and so forth. And the results were not no increase of infection, and the efficacy is better. And this is the Calgary experience combination biologics. They use the 10 patients, 9 CD and 1 UC. All patients failed more than 3 biologics, and half of them more than 4 biologics. And they don't use dual biologic at the same time, but they add on. They use one biologic and add another one. Vido Adielo, Vido infliximab, and others. 6 refractory disease, 4 extraneous manifestations. All combinations were well tolerated. Also, combinations of calcineurin induction followed by Vido has been tried in many studies. Remission 50% almost, and continue to have it all over 1 year. In conclusion, there is a significant unmet needs still exist despite currently approved therapy. Agents in phase 3 trials include multiple novel targets, but the algorithms and comparative trials will be essential in guiding our wealth of upcoming new therapy. Thank you very much.
Thank you, Professor Osama, for your distinguished lecture, as usual, and as expected, always from you. And now I'm going to leave the microphone to my colleague, Professor Medhat Al-Sahar and Professor Ahmed Shawqi, to present the next speaker.
Thank you, Professor Ali. Our next speaker will be Professor Dr. Sherif Magaoud, Professor of Gastroenterology and Hepatology, Cairo University. Professor Sherif will present AI and IBD in 2020. Please, Dr. Sherif.
It's a great pleasure to be with you all today. Thank you so much for this very kind invitation, Professor Sherif Abdelfattah, Professor Mazen, Professor Amr Fatin and Professor Osama Abada, dear chairers, Professor Ali Gaballah, Professor Medhat, Professor Ahmed Shawi, and Professor Baha Abbas. In the coming few minutes, I'll be talking about an important topic, which is artificial intelligence in 2020, and specifically in IBD. My agenda will include a very short history, and then a very short definition and basic information we need to know, and then how did artificial intelligence change everything in the field of GI, and specifically, I'll end my talk with the changes in the IBD expected to occur from 2020 to 2040. The topic is really very old, since the 1950s, and they have been arguing whether artificial intelligence is going to replace the human being effort. Are we going to replace by machines? Are machines able to learn? And really, this is not a new topic. And we have to understand that by artificial intelligence, we mean that a machine can behave like a human being. It can think and it can solve the problems. And the way we are going to give a machine information is the machine learning. And usually the machine stores the data in deep layered material and then communicate data by networks and algorithms. And it can end up giving you the output of very intelligent information. And believe or not, machines are very smart, even they look to be smarter than human beings. Machines can be classically learned, such as when you give it an image, this is a polyp and this is on the left side a mass. Machine can classify this, tell you that this is a polyp simply, or this is a mass, in a very simple classification and a very easy output of information. But if you give more data about the vasculature, about the color, about the size, about many things, then you can get a more accurate output telling you that this polyp, for example, could be an adenomatous, could be whatever. So what you heard from Sherbini is totally changing within the coming years, because machines will be doing the job very accurate. And of course, we can learn a machine or give it information either by labeled data or unlabeled data, but at the end, the machine can cluster, compress data, and give you an output of information, and this output will reinforce the information and knowledge of the machine, which becomes really intelligent day after day, giving you better outcomes and better information. And the story is simple. You can imagine this big cloud of information. Believe it, we have a lot of medical information. We have a lot of information from the genome, from laboratories, from images, whether endoscopic, whether radiological images, whether histopathological. Even our smartphones have a lot of information of our patients. Smartwatches also. We have at least more than 2,314 exabytes of medical data. There is a big cloud of information. And at the end, all of this information would be taken, used by the machine. But of course, the only thing is that every image and every information should be very accurately collected, and the images should be of very high quality. The machine could use a generalized model which could be applied for your patient, either to stratify them, either to predict the outcome, or to predict the type of treatment which is most suitable to this treatment. From the year 2020 till 2040, we expect that a lot of change in technology will happen. Our field will be much easier. We expect this because we know quite well that in the coming years, we will have an advance in all aspects of artificial intelligence, specifically in speech recognition and facial recognition. Computers will be able, while the patient is on this, just facing the screen, to tell you if he is apathetic or not, if he's pale or not. A lot of his body language and facial language will be interpreted by computers. Machines could also analyze images and give you an output of clear diagnosis, almost definite and more smart than a lot of radiologists. Predictive analysis also is a very important aspect, which is fastly developing in the field of artificial intelligence. So what do we expect? We expect artificial intelligence to help us in diagnosis, in prognosis, in image analysis, stratifying our patients, and then to predict the outcome and, of course, the response to treatment. Artificial intelligence helped us a lot in all particular areas of the GIT. For example, in the esophagus, and as early as the year 2005, using artificial neural network helped in diagnosing GERD with a sensitivity not less than 100%. Imagine from the year 2005, artificial intelligence is starting to develop. And of course, by the year 2016, artificial intelligence could help a lot by computer-aided detection system to spot areas of neoplasm, early areas of neoplasm in Barrett esophagus with a sensitivity and specificity of 88%. Imagine how life will be easy, spotting early neoplastic lesions. And of course, when you go to the Argus project, and when they compared 6 specialized endoscopists, and they localized the areas where they suspect the neoplastic lesion to be occurring, comparing this with computer-aided detection algorithm, you can see that they were very, very comparable, telling you how artificial intelligence is really very smart. And in the field of cancer esophagus, early detection of cancer esophagus has changed totally the prognosis of this morbid disease. All of us know in most of our cases, once we diagnose cancer esophagus, it's usually in a terminal phase and in a late phase. However, starting to diagnose it early using convolutional networks will really change the prognosis and the outcome of this morbid disease. Really, because of artificial intelligence will help a lot in, of course, while we have new regimens of treatment, adjuvant and neoadjuvant treatment, all of these will change the prognosis and the outcome of patients. And in prediction and in scoring, we know, for example, ROCAL score, which predicts the risk of mortality in non-esophageal upper GI bleeding, artificial intelligence scoring because of the feeding of the machines with a great number of material and data. They will give us scores which are better, more accurate, and we can really utilize these scores with a sensitivity almost 100%. In acute pancreatitis also, neural network has helped us to assess the sensitivity, to assess the prediction of hospital stay with a very high sensitivity reaching 75%. Imagine a lot of our scores will end up even in inflammatory bowel. I think after applying artificial intelligence, we will lose a lot of these scores. In the small intestine, capsule endoscopy, which is a lengthy procedure, the report will take a long time, of course. Using artificial intelligence has helped a lot in minimizing the time of diagnosis by providing us by models which can easily diagnose, for example, atrophy of the villi, suggesting diseases such as celiac disease and many other intestinal disease, limiting the time, concising the time, and at least sparing a lot of the clinician's time. In the colon, a lot of advanced, all of us know that most of the systems will recently be provided by systems which can detect very small, tiny polyps, which could be easily missed even by expert endoscopists. Imagine that once you have a very small polyp like this, you can miss it easily, but by artificial intelligence and computer detection systems, really this is easily detected, and you get a sign at the edge of the picture showing you that there is a polyp in a sensitivity not less than 98%. And you can also see this system, which can really spot easily the polyp. Very simply and very easily, it will spot the area of very minor small polyps, as you can see here. And you can imagine that at a time, the difference between experience between endoscopists will be really nullified when we use such types of artificial intelligence. And you can really increase the yield of detection of polyps significantly. Not only this, but also the computer-aided based convolutional neural networks were used to improve the diagnostic power of physicians. And you can see here in this trial, convolutional neural networks were able to differentiate hyperplastic polyps from adenomatous polyps with a very high specificity and sensitivity, not less than 70%. And let me really tell you that what we heard from Sherbini now will change. No need to go through this headache of CUDA pattern, bit pattern, and so on. Even a lot of our classifications, I think we will not use, or we will use more simple, easy classifications, because it's very simple and easy to apply artificial intelligence. And for this reason, this scientific report reported that the computer-aided diagnostic system was really very comparable to the most expert endoscopist. So believe me, sometime they are going to replace a lot of experience in the field of endoscopy. What about in the field of IBD, which is the most interesting point? All of us diagnose patients of IBD, then start management, most of us by treating to target. You start to assess your patient clinically, and then you interfere in their lifestyle to improve it and give them a better quality of life. You want to prevent complications, fistulization, surgery, and so on. You want to improve the prognosis, and of course, by better, precise type of treatment. So which field of this do you think would artificial intelligence help us in IBD? And the answer is in every field of these. And how would this work? We have a lot of data in the field of IBD. This electronic health record data from the history, clinical assessment of the patient, and so on, laboratory data, as well as imaging, as well as the omic data, whether genomic, epigenomic, proteomics, a lot of this data will be analyzed, but really in a very special way. And of course, with a trained team, because there is a big cloud of information which need to be applied to the machine, and the machine should receive this sort of deep learning, whether supervised or unsupervised, but at the end, we can get out a model or a biological system which we could apply to give our patient what we really target, which is precision medicine. And this is the era we are targeting or aiming to, rather than not only targeting our therapy, but at least we have to precise our decision and precise our treatment. So at the end of the day, through molecular profiling and the risk-benefit prediction, you will find yourself dividing patients into groups. For example, for this group, conventional therapy could be the best. For the second group, biological could be the best. For the third group, an whatever biologic could be suitable for the patient. So we can stratify really our patients into different groups and give them the best suitable treatment. Artificial intelligence has reached this level of characterizing the imaging, even diagnosing cobblestone appearance simply by using these very accurate networks. The field is growing up very fast, and the artificial intelligence makes our research much, much easier. And in this study, for example, they used the artificial neural network to predict the outcome of patients using cytopheresis in ulcerative colitis. And it's not the study for the study, but it's how you can collect a big amount of data, analyze in a simple way, machine give you results very easily, and really correlations are very easily collected. And also in this study, when patients were followed were using azathioprine, their mucosal healing and the risk of surgical intervention was compared in patients who received azathioprine and those who did not. And of course, azathioprine patients were found to have better mucosal healing, and on the long run, they were at a lower risk of having the need for surgery. Studies will become much easier. Correlations, relations analysis will become very easy. Even simple ideas like seasonality in the disease, you can really get this from data you have in your machine. And in this study particularly, they found that in Crohn's disease, there is a seasonality in July and August, while in ulcerative colitis, they could not find this seasonality. Believe me, machines are able to form the models to predict the frequency of onset and the relapse and the severity of IBD and seasonality, for example, simply and easily and almost in no time. These fully automated diagnostic systems and really the endocystoscopy will really throw us at a head in the treatment and management of inflammatory bowel. These types of scope are able to show you if there is inflammation or not. Not only this, to grade the inflammation with a sensitivity of 90%. Believe me, it can also give you a lot of information about the pathology and if this patient has an endoscopic and a pathological evidence of healing. Imagine how information will change, even our scores we are usually using in our regular life, our routine. We know that there are challenges because the data is very big. We have to respect the patient privacy. We have to collect the data accurately. integrate the data in a very professional way. Advanced methodologies should be used by a trained team in order to analyze the data perfectly and then to apply it in a personalized quality of management for our patients. We are faced always by the medical budget, but we know that our search will jump at advance because we have a lot of data, a lot of models, a lot of information, and easily ways to analyze the data we have. So to conclude, dear chairs and dear audiences, artificial intelligence is no way the definite future of medicine. We and the generation coming will see a lot of change in the field of gastroenterology and specifically in inflammatory bowel disease, which is a growing important disease nowadays. Definitive improvement in all aspects, not only in diagnosis, but in management, stratifying, predicting outcomes of our patient will totally change. There are challenges, we know the challenges, but we have to go through them by rigorous studies and publications. Clinical validation and real life studies is very important. And at the end, we should get approvals as FDA for every particular outcome we have prior to implication of this on our patients in clinical care. By this, I would like to thank you all and enjoy this very important conference.
Thank you, Professor Sharif, for your very elegant presentation for the future.
Okay, now we get to the final talk in this session. It will be by Professor Maha Maher from Mansoura University. She will talk about ileal versus colonic Crohn's disease, if there is a difference. Please, Professor Maha.
Thank you, Professor Baha, and thank you for the respected chairpersons. Actually, it's very difficult to talk after Dr. Osama Abada and Dr. Sharif, very difficult actually. But anyway, I think it's a simple topic that I want to talk about. Is it worth to differentiate between ileal and colonic Crohn's disease is different, and if it is different, it has an impact on the management or no significant difference or no need because there is no impact. Let us start by that first described the terminal ileitis at 1932 by regional enteritis, predominantly involved the terminal ileum without any colonic involvement. And the other side, isolated colonic Crohn's disease discovered or described at 1960, after which they stratify patients into isolated ileal and ileocolonic or isolated colonic involvement, and after which we have three different parts related to Crohn's disease. We found a case like 25-year-old female, non-smoker. She was on oral contraceptive, presented by 1 year of recurrent attacks of abdominal pain and diarrhea, and presented complaining of element of arthropathy, left knee and wrist joint swollen, and inflammatory changes is present. Fecal calprotectin was 830, and when we did ANCA was positive and ASCA was negative. So if we put Crohn's disease as a differential diagnosis or inflammatory bowel disease as a differential diagnosis, specifically Crohn's disease, from this provisional data, we can mention it's going with ileal Crohn's disease, or it's going with colonic Crohn's disease, or actually it is difficult. The isolated colonic disease, Crohn's disease, which is restricted to the colon only, they found it occurs in 1/3 of Crohn's disease patients, have a female predominance. Mostly they use oral contraceptive, and in spite they found that oral contraceptive can be associated with Crohn's disease in general, but specifically presence in Crohn's colitis, associated often also with extraintestinal manifestations, erythema nodosum, pyoderma gangrenosum, frequently associated with eye and joint involvement. So if we return back to our patients, we can mention this a female patient with extraintestinal manifestation using contraceptive pills. So I can expect, or I can mention, or provisionally it is related to colonic Crohn's disease. Also, primary sclerosing cholangitis, specifically in Crohn's disease, associated with colonic disease, mostly Crohn's disease with Crohn's colitis, or specifically in Crohn's colitis, mostly mimic ulcerative colitis and less likely to be complicated by stricture or by penetrating disease. And moreover, they found also that left-sided colonic Crohn's disease associated with an approximately significant reduction risk for a complication. So Crohn's colitis less likely to present by a complication. Okay, on the other hand, what about ileal Crohn's disease? Is there a significant difference at the level of clinical situation? Actually, they found the high prevalence in smokers. You know that smoking is a predisposing or a risk factor for Crohn's disease in general, but they found that it is related or stick mostly to ileal disease rather than colonic Crohn's disease. Also, they found that ileal Crohn's disease associated with delay onset of diagnosis, reaching up to 2 years. So if you found patient presented by recurrent attacks of abdominal pain and diarrhea, and you think that such patient present or a differential diagnosis of IBD, and this patient's complaining for more than 1 year, think that this patient is not a colonic Crohn's disease. It's mostly related to ileal Crohn's disease because it's associated with delay onset of the disease. The ileal Crohn's disease associated also with the development of perianal complication or perianal presentation. Less likely colonic can be present like that. Arthropathy or axial arthropathy like spondylitis associated with ileal inflammation, even if the ileal inflammation is subclinical. The isolated ileal involvement was 7-fold increase in change in the disease behavior. You know that Crohn's disease, it's inflammatory or fistulizing or fibrosing or stricturing. The patient presented with ileal involvement are more likely to present with liability to change in the disease behavior. So the difference between, or the knowing there is difference between colonic and ileal not only impact on clinical presentation, but also for progression of the disease. You can know that complication more likely to present by ileal inflammation. Okay, what about microbiome prevalence? Is it significant? Actually, they found it is significant. Microbial community profiles shown to be significant to differentiate between ileal and the colonic Crohn's disease. And you know the significance of microbiome nowadays in our patient with IBD, and it's reflecting parameters related to the natural course, related to treatment, and so on. This difference actually is independent to the biopsy site or inflammatory state or the genotype, only based on this patient is ileal or colonic. Ileal Crohn's disease observed in certain species like Faecalibacterium or Rhizoburia or subsets of Clostridia, and high abundance also or high prevalence in Enterobacteria and E. coli compared with colonic Crohn's disease. So special strains found to be present in ileal Crohn's disease and not present in patients with colonic sector of Crohn's disease. They found also about abundance or prevalence of certain bacteria like Fusobacterium strongly correlated with disease activity in ileal, but not correlated with colonic Crohn's disease. The presence of E. coli also correlating with severity, disease severity. It has been observed that invasive E. coli more prevalent in the ileum. So if we found or try to summarize the microbiome, we found such microbiota is prevalent in ileal Crohn's disease, can predict the progression and can predict severity, correlating with the severity of ileal, but not in the colonic mucosa or colonic Crohn's disease. What about genetic expression? Actually, they found that genetic difference between colonic Crohn's disease or Crohn's colitis and ileal Crohn's, two molecular phenotypes found significantly different. The RNA data collected from tissue, colonic tissue and ileal found significantly different, and different accessible region, highly discrepancy between colonic and ileal Crohn's disease. Okay, the most important point, it's okay, there is difference between ileal and the chronic, but there is difference in response to therapy, has impact on response to therapy. Yes, They found that isolated ileal disease observed to have a negative predictor in response to anti-NF. And also another studies related to certolizumab randomized trial showed that colonic Crohn's disease and ileocolonic were more achieve remission in 6 weeks. For analysis for VIDO and ustekinumab phase trial, still no more results can be present for such a case. This is a summary for the response of the therapy for different studies related to Unity 1, Unity 2, and Gemini also, comparing TNF, anti-NF, and ustekinumab and VIDO. And you can notice here the ileal versus the colonic one for the first study, 16, for Sandborn 16 versus 62, for example, found response versus 23 in colonic Crohn's disease. In another example for ustekinumab, say in Gemini study, we can find that 6 out of 37 patients in ileal Crohn's disease responding only, while 8 out of 62 from colonic Crohn's disease had more promising response rather than ileal disease as regard to such studies. What about fecal biomarkers? I can use fecal calprotectin in ileal Crohn's disease, same like colonic Crohn's disease? Actually, no. They observed that ileal Crohn's disease has not have increased calprotectin or significantly increasing calprotectin even in the presence of large ulcers. On the other studies, they found that capsule endoscopy as a gold standard suggests that fecal calprotectin has modest activity in patients with ileal Crohn's disease. So fecal calprotectin is important, but sensitivity is modest in ileal Crohn's disease. The antibodies for ASCA, Saccharomyces, found to be present in ileal patients compared to ASCA negative in patients with colonic Crohn's disease. And ANCA or p-ANCA found to be positive in patients with Crohn's colitis, like patients with ulcerative colitis. So phenotype here is very important, putting in your consideration, because as you know, generally, we use ANCA and ASCA to differentiate between ulcerative and Crohn's disease, but also we can differentiate between ileal and colonic Crohn's disease. What we can conclude from these points, the data presented suggests that ileal and the colonic Crohn's disease phenotype could be separate disease, and consideration should be given to distinct classification system, ileal dominant or isolated Crohn's disease like that. We have the conventional subgrouping, ileal, ileocolonic, and the colonic that we usually use, but the proposed new disease classification was the ileal dominant, ileum dominant, including the ileal and the ileocolonic, and the colonic dominant, including the colon only, based on the difference mentioned. This is a picture to our figure summarize that the difference between colonic Crohn's disease versus the ileal Crohn's disease as regard to gender, as regard to smoking, as regard to the disease progression, diagnosis using of serological markers, using of microbiome, and using also, and its impact also for the treatment of biologic therapy or other therapies when we diagnose colonic versus ileal Crohn's disease. Thank you very much.
Thank you very much, Professor Maha, for this elegant talk. Now we are going to close this session, and thanks very much for our great chairpersons, and honored to be with these eminent speakers.